this person asked me to see if I can figure out what's going on with their anatomy, with their body, as to why they're having left leg pain and really not capable of standing for any duration of time on that leg without it hurting or without having to take some kind of a rest. And there's an extensive history in this case. I'm not going to read it all right now. There's an extensive history of issues, medically diagnosed and then felt by the person. And understand, it's very daunting when you see something like this. It's a lot to take on, and you should feel that way because it is. It's history, and it's 8 years, but realistically more than that of things. And sometimes, after you've made sure that they're safe to work on, that kind of thing, scan for red flags, you want to just ignore a lot of this, and you want to assess the anatomy as clearly as possible, trying to figure out what it's doing and why it's doing what it is. Understand the mechanics, understand how it's loading up certain parts more than others, and then you can look back on that. This is what we're going to do here. We can look back on that with a clear view and hopefully make sense out of it. You can make a lot of sense out of what that person is feeling. We're going to make the case that it is not so much the knee that's the problem, though there could be issues with it, but we're going to say that everything else in the body is loading up onto that knee. Everything else is putting the wrong weight and the wrong kind of usage into the knee. Even though you could argue that the knee is just the knee and that, the neck is just the neck or the shoulder is just the shoulder, even though that can be the case, with what we're going to try and show here, it would be very difficult to justify just looking at the knee, solely looking at the knee, because so many other parts of the body are changing the way it works, and it wouldn't make any sense not to try and fix those things also, or at least to figure out why those things are doing the things they're doing and how they could contribute to that knee problem. First, I must say, I am not a doctor. None of this is medical advice or a diagnosis. This is for educational and artistic purposes only. I have to do all of this at a distance. I can't directly palpate anything. I've got videos and images only, and these are educated guesses at best. They're guesses. That's the reality. I can't physically be there. And I'm going to be wrong on some parts. I'm okay with that. Hopefully you are too. And that's how it's going to go. So let me just pull up a video to start. So this is a video of a person walking. I'll just let it play through here. So just notice, I'll play this through a few times. Notice how first the upper body is moving on that left arm swing. When that left arm comes forward, it's very pronounced in the way that it rotates. It's not rotating smoothly. It's a very staggered, kind of stunted arm swing. We're not seeing a smooth rotation here. We're seeing a harsh kind of forward push. Some of it could be because of the leg pain, but nonetheless, and hopefully as we'll see properly reveal, that arm is not doing its job of smoothly working using the pliability of the tissue, which is probably left the side of the shoulder here. Going back to our static image, so what it should be is, as say that left side is coming forward, we see the opposite side doing the same thing. Usually the leg slightly precedes the arm, but it's nice smooth movement, oppositely coupled, if you will. And though things should move together, you'll find no argument from me on that. Things should definitely move together in the body. It should move gradually together. It should move smoothly with a bit of tissue taking some of the weight or taking some of the slack out. So what should really happen is that arm comes forward. Let's say we've got our humerus right there and we've got our scapula. And as that arm swings forward, the body's going through its, standard rotation. It's pulling through the musculature. Maybe that's, traps and rhomboids. It's pulling through that musculature, and we start to see a rotation forming higher up, as it should be. And then that rotation on the vertebrae above and really through the whole shoulder girdle, it should start to pull through into the next area. So the tissue slack is taken out. And then once that slack is taken out, it pulls through into the next area, encouraging it forward. Now understand this is very fast. This is all happening. It's not a slow process by any means. But it works its way gradually down the spine, sequentially. It's supposed to do that. I'm drawing it too large here. Obviously, it would be a lot smaller. But it gradually works its way down, all the way down, taking out the slack in the tissue. And then we, of course, get the opposite thing kind of happening from the ground up, meeting point in and around there. But in any case, it should be a smooth, slow thing. The body, yes, of course it should work together, but it shouldn't work like a chunk. It shouldn't work, like a big corkscrew. That's the only way I can kind of see it. In my mind, I go, okay, it's got, corkscrew like that, spinny thing in the middle to poke the wine bottle, and then it's just operating all together. There's an illustration for you. So it's just operating all together. It doesn't have individual, slow, smooth motion between all those joints, which it really should have to balance that movement. When we don't have separation, partial separation of the parts, what we get is a concentration of forces. Maybe it's one spot here that is taking too much of the brunt, for instance. And so what often happens in that case is that we get a lot of strain in that area because there's too much force running through that particular spot. And it doesn't show up right away necessarily. It could take years or even decades to manifest. But as we start to move the whole thing without flexibility, as we start to move the whole thing, just kind of hammering down the whole thing on top of one particular spot, it can be a real problem. In this case, we're going to say, and we're going to build this up a little bit more gradually, we're going to say that because a lot of the body moves in this big way, it's a rotational movement we're limiting. And so we're taking up a bit more of it in the knee. The knee is doing too much rotation. It's really not meant to do much rotation. It can do a little bit, but it's doing more than it really should. And so we want to try and figure that out. I'm just going to clear this up here. There we go. So in addition to this, if you look at just the case history, there were 2 traumatic shoulder injuries. So again, we got a humerus there. Ooh, drew it a little bit better this time. Okay. And here's your AC joint, etc. You get the idea. There's a scapula for you as well. There's 2 traumatic shoulder injuries. I won't go into how they came to be because that's not really relevant, but there was some damage there. And usually when we have sustained true damage, we get inflammation, so the whole thing winds up on us, gets all hot and stuff, and then we get tissue thickening around that site. Maybe it does still moves potentially relatively well for a lot of the time, but as that tissue thickens, it's as if the whole thing kind of gets bound together, like it gets to be not moving individually either. And so this is actually a good case to start to explain further why we're seeing this really exaggerated left side arm motion. Because when we have this thickening after these injuries, this whole thing's going to now move together, what should be a gradual smooth motion of arm swing from the glenohumeral joint, or the true shoulder joint, to actually being carried through instead by the scapula, which is a pseudo joint, and certainly it's supposed to move, has a fairly high range of motion, but it should be not as much during that arm swing. A lot of it should be GH joint, shoulder joint, another word for it, should be through the GH joint, but we're getting this whole upper girdle thing, and this is also going to be carried through the clavicle in the front, not pictured here, but the clavicle in the front as well. So we've, again, got another good case for why this whole upper part of the body is moving in this singular, non-smooth, non-dissipating motion. So we want to take a further look at how this is moving like a block, and we're just going to switch to our lateral view or side view of the body. And I'll just point out, one quick thing here, that we've got some increased curves and maybe a forward head posture. So just drawing a quick line like this. I'll just move back here a touch. And I don't know if you can see this, how clearly you can see this, but I feel like we've got a forward head posture, which ultimately on its own is not a big deal. And many of these things on their own are not problems by themselves. But the fact is, in combination with all the other things we're going to mention, it can be more of a problem. So if the head is forward, we know we've got generally a little bit more of a round through the spine. It's got to come somewhere. And you can clearly see it here where it's rounded out, as if it had been kind of pushed back. This is the thorax. We call that a kyphotic curve or an increased kyphotic curve. Not a pathologic one, but an increased one. And then you can definitely see the hollow that's kind of come into the neck. And then the same in the back. The neck and the back are generally what we call lordotic curvatures. They're anterior or whatever you want to call that. But they're concave in the back, convex in the front, and then we got the opposite in the thorax. You'll notice too, this is a skinny guy. He's small, but it's as if the belly is being pushed out, so that curvature in the lumbar spine is a bit bigger than it should be. And we can see this just to show you this. We'll talk about this image a bit more. If you look at the ropiness, the density of these erector spinae muscles, they're a little too big. He seems to be a muscular person, but considering he's not doing a ton of back exercises, this is a bit much. They're kind of imbalanced. So these are excessive, to say the least. So we know we've definitely got some increased curves. Now, when that's the case, what you're generally going to see, you can see it, you can see it here really well from this range to this range. We get a lengthening of those spinal muscles. Now, there are a ton of spinal muscles, and I've talked about this, I don't know, a few hundred times before, but the spinal muscles largely run vertically. There's like the iliocostalis, which is going all up that way. There's a spinalis. They're all running like this. They're all running in bands like this. Splenius, semispinalis, cavity, all these. Well, you know the ones anyways. There's a ton. I'm not going to try and name them, but they all run up and down. They're the erector spinae as a group. And then even the individual intervertebral ones run in a large way, largely vertical. So when we increase the curvature, when we bend a person forward, we increase the curvature in the back, they get longer. And when they get longer, they become more taut. They get increased in tension. It's just like stretching out a rubber band, except, in fact, this rubber band happens to be reactive to the way you stretch it. It doesn't want to be stretched too far, and it will start to resist. Ligaments are a little bit more passive in that they don't have the same kind of active contraction, but nonetheless, they have an end range. And so when we increase the curvatures here, more than likely, you're going to see it at that end range. And when it's closer to the end range, when we try to introduce other motions, whether that's rotation or whether that's side bending. So let's say we'll just arbitrarily pick, we're saying these guys are too long on the right side, they're too long. When we try to introduce side bending to the left, they will try to be lengthened further, but it doesn't happen, or it's going to be a lot less. Same with rotation. If I attempt, just pull that away. So again, we're saying the right side's alone. If I try to rotate to the opposite side here, I have to lengthen these at least a little bit, and especially the smaller ones as we go into that rotation. So they have to give, just like we were talking about in the gait cycle. They have to give. If they're already at their limit, because we're so flexed forward, or even we're just generally flexed forward, kind of consistent throughout, I'm going to see some real reduced motion. And when I try to initiate the normal bits of rotation of the upper and lower parts of the body, when I try to do those little bits of side bending when I walk, we're going to have a lot of trouble, because those motions are necessary to get a good way of walking. But I'm going to move, not like a sequential, smooth, flowing motion. I'm not going to get a nice kind of curve from one side to the other. I'm just going to get the whole thing working like a block, just like that, as if it was all crunched together, and now it's just hammering down on one spot. So it's got to move smoothly. It's got to move sequentially through the bones, each tissue given. And when we have an increased kyphotic curve, when we have increased kyphotic and lordotic curves here, we're taking out the slack. We're taking out the give in the tissues. So again, we're seeing this whole thing operating together, but not in a good way. So I have here just a video of some side bending. I did a video of a rotation as well, but this one just shows it that much more. So I'll play this, and then we'll go to more of a static picture. He's going to go towards the right initially, and that moves relatively well. Look at the erector mass, the erector spine. Now he's going to go to the left, and just notice that kind of in the middle of the back, I'll replay that. Notice how in the middle of the back, it's not really moving. So this would be like the T10, 11, 12, L1, L2 area. It doesn't move when he goes to the left. Notice how it maintains a relatively straight position instead of curving. So to the right, again, to the right, we get a bit of a curve through here, curves well, which is what it's supposed to do, especially in this area. And then it doesn't curve as well. So that's kind of telling us we've got something restricted there as well. Switching back to our static picture. So just as a real simple example here, we've got our rib cage on either side, and you have two of them, and then the end of the rib cage is at about T12. It goes all the way up to T1, and there are about 12 ribs. I'm not going to draw this, right? And I'm okay with that. There you go. There's about 12 ribs, 12 on either side, 24 in total. And those ribs attach to the thoracic spine. Past that, we get the lumbar spine, relatively big vertebrae. Again, I'm not going to draw enough here either. But you'll notice that it goes from caged, because if you look at the thoracic spine in the front, all of these ribs actually attach to the sternum, a pretty solid bone. They attach to the sternum through cartilaginous joints. And when that's the case, they're going to move more as unit. When we suddenly get to the bottom of the rib cage, we've got these two floating ribs. So ribs 11 and 12, I'll just draw them in like that, 11 and 12, and they're actually smaller than I've drawn them here. So we go from all caged up, moving more as a chunk. There's, of course, supposed to be some individual movement here, as described before. But then we've got this area that just suddenly frees up. Lumbar spine itself, too, really mostly flexion, extension, mostly just extension, let's say a little bit of flexion, the lumbar spine, L1, all the way down to about L4. Then it starts to rotate side bend again. But we've got two kind of less mobile areas with this pretty mobile area right in the middle of it. And that's where the movement is supposed to be occurring. That's what we should be seeing, and we're very clearly not. Hopefully the video was clear enough to show that. But we actually have a high area of mobility, usually between the thoracic spine, the lowest part of it, and then the lumbar spine. That lowest part, the 11 and 12 area, actually moving quite well. Some side bending and rotation, but it's not doing that in this case. So we've definitely lost a lot of the motion again, as we can see in our thoracic region, but we've also lost it in another spot at the kind of lower end of this whole thing. So when we go to more of a static image, these are just screen captures from the same video, you'll also notice that the hips are contributing more on the one side than the other. So we talked about how the erector mass was a bit different. We see a bend through here. Again, hopefully you can see just like you got a little bit of shadow, and then the erector spinae muscles on either side of that. They do bend in this case, on this right side bend. And then when we go to the left, we got this relatively straight chunk right there. So relatively straight chunk right there. It's not working well. And in addition to that, if I just throw in some lines here, you'll notice the line is placed in between the legs here. That was done on purpose. You'll notice that on this right side bend, that the pelvis is pretty much in the middle. That means a lot of this bending to the side is coming from the spine, which is great. That's what we should be seeing. Whereas if we go to this other side, a lot of the pelvis is opposite. So it's actually had to translate to the side. It's had to side shift, which it shouldn't normally be asked to do when we're side bending. So that means what we're not getting from here, we're probably getting from the hip joints on either side. Now again, the body should work together to an extent, but there's going to be areas that do certain actions more than others. And when we see accessory motions, when we see extra needed from a certain area, we know that there's a problem in the area that should be doing its job, because now it's not. And so we need to figure out, what that means, why that is, and try to see if we can come up with a solution for that. In any case, we're just saying a lot of this whole thing doesn't move really well. It's moving like a chunk, it's moving like a corkscrew, whatever you want to call that. And so whatever's below it is probably taking a lot more of the brunt. Now, I want to say, I think I've said this in almost every, structural analysis video that I've done. It's very hard to figure out what the pelvis is doing based on video and pictures. It doesn't matter what. It's very hard to do because the sacroiliac joints, it's these ones, the sacrum and ilium, and the pubic symphysis, that's the one in the front there that links the two pubic bones together. Their movements are very small. They're very important movements. These are synovial joint in the back, and then it is a cartilaginous joint in the front, and they do move despite some opinions, but they definitely do move. And you just can't do it by visual inspection alone. You got to get in there. You got to actually test those joints. That's the best way to really understand what's going on. That being said, I'm going to guess that we don't have a lot of pelvis movement. And I'm guessing that has to be made up for somewhere else. Lack of mobility through here. Let's say this is just all wired up and not fused of course, but it's not moving because maybe that sacrum's in a bad spot. We've got maybe some strain that happened to the ligaments. It's thickened and it's locked out, and it's altered. It's altered the way things work. Always remember that these joints, the sacroiliac joints and the other ones, they have nerves that go to them. They have nerves that come from the CNS, and they help to calibrate muscular action above and below it. Anything that attaches to it, they'll calibrate the same muscles that those nerves go to. It's just the same as if your elbow was strained, you'd probably have reduced motion in the muscles as a protective mechanism. So understand that even though the joint movement is small in the pelvis, it is still relevant because it's weight bearing everything above it. It has to take on the load of the entire upper body, really at any given time. You could say the same thing about the feet and the legs and the knees. Those are all really important too, but the pelvis is of no less important. It's a very large structure too, so consider how much it takes on. It's really designed to take on a lot of load. So when it doesn't move right, it's going to have effects. Now with that, the lack of mobility here has to be made up for. It's a pretty simple rule. If we want to maintain anything close to normal motion, if we want to maintain moving, walking, even standing, we've got to take it from somewhere else. The lack here probably means it has to go somewhere else. Now, a lot of the times, the lack of motion in the pelvis could end up meaning that the thorax, the lumbar spine, even the shoulders and neck have to move differently to compensate. And that's just to turn around, maybe do a blind spot check in your car, something that affect, or just something as simple as the gait cycle or running. However, we've established, feel pretty confident that we've established that upper part in multiple parts of the spine are not moving. So we only have a limited number of things. The next spot we can go to, I don't know why that's gray. Ooh, terrible color. Okay, there we go. Is the hips. And it turns out this person, this person is reporting that they've got lots of hip pain intermittently, but we've also got clicking and popping in the hips. When you force the hips to move differently. Yes, it's very tolerable for a long period of time. You know, they're a durable joint. They're very, very strong. But can they do it forever? Can you ask any joint to change the way they work indefinitely? And the answer really should be no, because maybe 2 years down the road, no difference. Maybe 10 years down the road, no difference. But at one point or another, if you're doing something very different with your body, way different than what it is used to, what it's been designed for, what we've evolved for, however you want to look at that, it's going to create a change. And that can often mean change in the tissue pliability, in that it could stiffen or it could loosen up quite a bit. If we're getting a clicking, popping sound, yeah, it's not dangerous. Lots of people have that. But it's enough, it's frequent enough to be noticed, and it can be associated with what's going on elsewhere in the body. So that is worth thinking about. How has he been using these hips for many years? Again, figuring out that pelvis, whoa, that's a difficult one. So going back to our posterior picture, just going to clean this up again. Going back to that posterior picture in a really, really simple way. Hopefully you can see this. It looks like, if I just kind of draw the curves in, I'll just draw right over top. It looks like we've got more weight being drifted, and it is slight, but it's there, it's consistent, being drifted to the left side of the body. And this is actually consistent in the walking video too. Just have that back up. And so you'll notice, talking about the rotation, but just look at the bend to that left side, that little exaggerated bend that this person does as they're walking. So it's a little bit of a left bend. The body kind of drops to that one side. So again, that's trying to show that we're disproportionately weight bearing on that left side. So when this is the case, even if it's just, if we got an extra 5%, I think it's a little bit more than that, we've got a little bit more of the body leaning to the one side. Again, not a major problem, but it means that in general, we're always putting a bit of extra pressure on that left leg. Whether they're standing, and it seems to be even a little bit more in walking. Not a big deal in the short term, but over the course of one's lifespan, this can start to be an issue. If we wear down one side faster, then we can rebuild the tissue, because the body's always being broken down and we're always repairing it. That's every tissue in the body. Don't worry about it. Most every tissue in the body is being broken down and repaired constantly. If we're wearing it down a little faster than it can be repaired, then you're going to notice it. We're going to have some problem. So we can say, just really, really simple, that the left side is under a bit of extra pressure or compression, however you want to look at that. Non-pathologic compression, but compression nonetheless. In addition to this, we're just working our way down the leg. If we look at this left foot, so understand that, left and right, it flips when you flip the image or when they face the other way. So this left foot is slightly externally rotated there. That's the worst arrow I've ever drawn. There we go. Slightly externally rotated. Again, not huge, not noticeable, but it is a little bit externally rotated. But if you look at the knee, it's relatively straightforward. So when we do this, when we have the tibia and the foot externally rotated, by comparison, the femur would be internally rotated. And so that means that this knee joint, there's the tibia there, and there's the femur right about there. There we go. Femur, we've got a spin occurring. Now, I believe some people call this a tibial torsion. You can call it whatever you want, but we've got a bit of an extra spin here. Now, it's only supposed to do this to any, like the twisting motion of the knee. It's only supposed to do this when we're standing up straight, locking mechanism of the knee. But it's not supposed to go totally to the limit. It's just supposed to limit the tissue movement there. It's just supposed to kind of like brace the knee a bit so we can stand for long periods of time. It is definitely not supposed to happen, normally though. And just to even exaggerate this further, and I will tell you, let me get rid of all this. I'll tell you, this person actually came up with this entirely on his own. Good on him, because I wasn't thinking about this at the time. So I'm just showing two different pictures. So here on the left picture, he's turned his feet in perfectly straight. This is normal standing position on the right. And you'll notice on the left side here, when he goes and tries to put that foot straight, hopefully you can see this clearly. It's small, but it's relevant. The ankle goes outward. It's kind of like it's sticking outward. We would call this like an internal rotation and inversion of the ankle, though, by comparison. And when that occurs, this is just by him turning the feet in, forcing it to happen. By him turning the feet in, now we can see it's even further exaggerated, the angle of the leg here, whereas here it's a little more straight up and down. Nothing too bad. So when he forces that foot in, it exaggerates what's going on. Now, when we have that, that's not even close to where that is. Hold on. Hang on. There we go. Now, when we have that, there's the knee-ish. When we have that, you can see that the femur, by comparison, when we draw that line out, it would be, and I'm exaggerating this, of course, but it would be comparatively pushed in. Just kind of like that. Now, again, it's not as if it was being forced that way by an outward force, but it is getting pushed out. Remember, too, though, it may not be an outward force, but the body above, because it tends to lean left, and again, we can still see it in this image, because it tends to lean to the left side, we're loading that left side even heavier than it should be. It's a disproportionate amount of weight. And so it wouldn't be unreasonable to think that maybe, because that femur is being pushed in, that we've got some lengthening of the tissues, maybe even a little bit of strain on that medial side, on that inside. And that is actually what's reported by this person, noticing some problems on that left leg medial side. That's where some of the pain is coming from. So that's a problem. Again, we might call these things torsions or spins, but we've got a few layers of mechanics going on here that are putting that knee in a bad place. And again, the knee, if you look at the history, we're going to look at a little bit more. If you look at the history, there's not much that's happened to the knee itself. It's not like it was hit with a hammer or something. There's no specific traumatic injury that started with it. So the way it's being used makes as much sense. And I'll say, definitely the knee must be dealt with. It needs to be addressed because it's had a long history of being in pain and being a problem, and so it will need some care. But that being said, the rest of the body also has to stop doing what it's doing to the knee. It's forcing itself to move. It's forcing the knee to move in a way it shouldn't. It's forcing itself to load that knee in a way it shouldn't. And so probably getting rid of that's going to make a big difference. So hopefully that's made some sense. Hopefully this is good. So we've got 8 years of pain. Sounds reasonable. It's taken a while to get there. It probably started way before that. And if you look at the trauma history, which I won't get into with any more specificity for confidentiality purposes, and these traumas, a lot of them preceded it. Chief complaint being the left knee. MRI showed minimal fraying of the left meniscus. Nothing major, something a lot of people would have, but he's got, in addition to that, a whole bunch of pain and a loss of sustainability and standing. Broken left ankle in high school. Again, another one of those things that happened well before this leg pain really started showing up, even before the 8 years. We've got bilateral hip pain, snapping of the hip pain, femoral remodeling on the right. And so, again, if we're using these things, if we're using the hips excessively, yeah, of course, perfectly reasonable to say that. Gluteal tendonitis, left leg posterior tendonitis, are the muscles being used effectively? Are the muscles pulling on the tendons effectively? Could that maybe be causing some irritation to that area? And then what happened, and these were several traumas to the left shoulder, multiple traumas to the back. These easily explain some of what we're seeing in that middle back, and even in the thorax, what's going on. Again, I won't explain the nature of the back traumas, but just understand that they were severe enough to warrant that they will change the way the body moves. Very reasonable to say. All that stuff, that's all great, that's fine, but the only way to test any of this is for someone to fix these movement incapacities, these problems in immobility, and see if that doesn't correct it. See if it, by making a lot of these problems go away, doesn't make this person feel better, have reduced pain, have longer periods of standing without tiredness, without pain. I certainly can't do that through the internet. Hopefully someone else can, though. That would be fantastic. Anyways, this has been Elge. Simple Lines Anatomy. I hope that made sense. And if it didn't, just ask.